Hello, everyone. Welcome to the Organizational Ethics Consortium, which is hosted by the Center for Bioethics here at Harvard Medical School. I'm Charlotte Harrison. I co-chair the consortium along with Kelsey Berry. Today, we have the privilege of presenting an outstanding panel of clinicians and researchers whose work has focused on equity in digital health. Digital health tools hold the promise of improving patient experience and possibly health outcomes, but it turns out there are often differential effects on different populations of patients. How can healthcare organizations use these tools in ways that mitigate rather than exacerbate health disparities? Before we hear from our panel, just a quick note about this consortium and other consortia that may be of interest. As the field of healthcare ethics has developed, the predominant concerns have related to the ethics of clinical medical professionals, of health researchers, and policymakers. You will find consortia on each of these topics here at the Center for Bioethics, as there are always new and difficult issues to discuss. Upcoming programs in each area are featured on the center's website at the link you see. This organizational ethics consortium was founded about 10 years ago in order to consider some aspects of healthcare ethics that have been less widely explored, asking what ethical challenges face organizational leaders at various levels. What are some fruitful ways of thinking about them and some possible solutions? Primarily, we hear from and about healthcare provider organizations such as hospitals and health systems. Occasionally, our guests represent professional medical societies, biotech companies, independent research organizations, and the like. Today, promoting equity is a common key challenge for most healthcare organizations. It's been a common theme of many of our programs this year. And please note in the upcoming March 29th program, when we look at some complicated organization level decisions regarding integrating medical and social care. Finally, as a related goal in highlighting organizational ethics, this consortium has been aiming to build a community of interest in this field, including fostering collaboration. With that in mind, we strongly encourage folks to comment freely in the chat during the program and identify themselves if they would like to. Now let's turn to the chat and other ways that you can participate today. As an audience member, you have two ways to participate in the program. One, you can use the chat box to share your thoughts at any time. Also, after the panel discussion, there will be a Q&A period when you can use the hand raise function to signal that you'd like to share your question orally, and you'll be recognized. Returning to the substance of our panel, now it's my pleasure to introduce Dr. Elaine Kung from UCSF, who is our guest moderator for today. Dr. Kung is an assistant professor of medicine at UCSF and co-director of the Program for Digital Health Equity at the UCSF Center for Vulnerable Populations. She's a practicing primary care physician and clinical informatician at San Francisco General Hospital, which is the safety net hospital for the city. Her research focuses on leveraging technology and implementation science to serve two primary goals. First, to advance chronic disease equity and to improve equity in the delivery of primary care. Dr. Kung is principal investigator of several federal grants that focus on implementing digital health tools for these purposes. Her research has been featured in Stat News and Time Magazine and published in JAMA Internal Medicine, JAMA Network Open, Nature Communications, New England Journal Catalyst, and Health Affairs. Dr. Kung will introduce the rest of our panel. Warm welcome to each of you.
Thanks so much for that introduction. I'm going to go ahead and share my screen. I'm really excited to be with you all today and talk a little bit more about promoting equity in digital health and some of the ethics associated with it from an organizational standpoint. So as was mentioned earlier, I'm really joined by a really esteemed panel today. So I'll just go through and introduce our entire panel. We'll first hear from I'll start with some brief remarks, and then we'll hear from Dr. Courtney Lyles, who is a professor in the Department of Public Health Sciences at UC Davis, directs the UC Davis Center for Healthcare Policy and Research, and whose research really focuses on harnessing health information technology to reduce inequities in health and healthcare outcomes. Her research portfolio spans digital health design and testing, evaluation, and implementation, and includes several large digital health studies for improving diabetes, depression, hypertension, and referrals to community-based health and social resources. We'll next hear from Dr. Deepti Pandita, who's an associate professor of medicine and chief medical information officer at UC Irvine, where she leads the informatics efforts at UC Irvine Health System. She was previously CHIO and program director of the informatics fellowship at Hennepin Healthcare in Minneapolis, which is the safety net hospital in Minneapolis. Dr. Pandita is really an award-winning health system leader in using technology to improve care delivery for historically excluded communities. Dr. Sophia Richardson is an assistant professor in the Department of Population Health um, and director of the program for digital health equity at NYU Langone Health. Her research also focuses on developing and implementing high-impact health information technology and clinical decision support tools. And then our discussant is Dr. Francis Shen, who's a professor of law and faculty member in the graduate program in neuroscience at the University of Minnesota and the chief innovation officer at the MGH Center for Law, Brain, and Behavior. He teaches bioethics and artificial intelligence at the Harvard Medical School Center for Bioethics and is part of the NIH Bridge to AI effort to build ethical and trustworthy AI. So really have a great panel, and we're excited to engage with you all in the Q&A session. So what we'll go through here today is I'm going to just start off with some introductory remarks just to make sure we're all on the same page in terms of what we're talking about with digital health, the types of disparities in digital health exist, and then some solutions really from an organizational standpoint that exist to advance digital health equity. I'll then pass it off to the rest of my panelists to really go into some deeper dives and some case studies in their own institutions. And then we'll close off briefly with some of the ethical considerations that came up from these case studies and have a couple of prepared questions for us to discuss, as well as really we'll open it up for you all. Let's go ahead and get started. So I think the first thing I want to start off with is just when we talk about digital health, what that means. So oftentimes, especially since COVID, when people think about digital health, they're thinking about specifically telehealth and really sort of what exists here in this top left corner. So virtual visits. So this is sort of patient to clinician synchronous interaction. And what I like about this framework here is I think it highlights that there's really a wide variety of telehealth tools. There are ones that are patient to provider focused, which is along the top, and then ones that are clinician to clinician focused. And in particular, there's a variety of patient to clinician tools that are what we call sort of store and forward tools, or are things that you might think of as remote patient monitoring or patient portal tools that really help advance access to care in an asynchronous way. And then there's a variety of tools that clinicians also use for digital health or for telehealth. And this is one section of digital health tools, but the WHO has a pretty broad classification of digital health interventions. And I want to just walk through it pretty quickly just so that everybody here is on the same page about sort of the span and the breadth of digital health tools that exist in medicine and in healthcare, and ways where inequities may come up when they're being used. So their classification has four large categories. The first is really focused on what they call clients or patients. And so these are some of the things we think about, really targeted communication to patients, personal health tracking, some of the mobile app tools that exist there. They also have a group of tools focused on provider-facing ones. So here you see EHRs in the 2.2 category, telemedicine in the 2.4. It's really ones that those of you who are clinicians in the audience might be pretty familiar with. They have two other categories that I think are worth highlighting because they do come up in how we deliver healthcare. So a group of categories of tools, they are focused on health system managers. So these are ones looking at human resource management, supply management, thinking about financing. Certainly in US healthcare, a lot of our digital tools have to do with how we bill and how we finance. And so these are areas, again, where you may see inequities come up depending on implementation. And then the last one is really focused on data management, which we are increasingly recognizing as important as a lot of these new artificial intelligence tools come up. So it's sort of data collection, management, how we use it, how we exchange it. So with that background in mind, thinking about the types of digital health tools, I want to provide a couple of frameworks for thinking through how inequities come up, and then provide just a brief landscape of the data of what we know in terms of any inequities that exist in current adoption. So the first framework I want to bring up is one that Dr. Lyles and our group of colleagues over here in California, we wrote about. And oftentimes when we think about inequities in digital health, there's a lot of focus on what happens at the individual patient level. And what we want to highlight, and a lot of advocates in the space really recognize that there are multiple levels of barriers to adopting a digital health tool. So there's certainly sort of what exists at the individual level. Do they have the skills necessary? There's also barriers that exist at a community level, at the organization level, sort of what workflows exist, what investment infrastructure might exist in a specific healthcare system. At a policy level, how easy we make access to broadband for different communities. And then and the bottom, I really want to highlight the intervention level, because this is increasingly recognized as something that's important with these new tools. So are they being designed for diverse populations? Are we designing for the margins? Are we designing for people who may have challenges using tools? And then to break this down really at a more granular individual level, um, I think largely when we think about sort of barriers to adoption, what I find to be helpful to think about is from an individual level, there's sort of the first group of factors that may impact, which is sort of like access. Does somebody have access to the device or the internet, or like even at a healthcare system, does the healthcare system have access to the tablets they need, or the internet that they need? So in our safety net system, some of our community clinics don't actually have Wi-Fi. And so having tablets to do video visits wasn't very helpful because they didn't have very high quality Wi-Fi. And so this is something that not only happens at the individual level, but might happen at a community level or at an organizational level. From there, there's a next group of factors really that I think of sort of in the skills or digital literacy space. And these are, of course, at the patient level, but also thinking from a organizational level, do your clinicians have the skills to conduct telemedicine visit or to really engage with remote patient monitoring data? Do they have the workflows for that? And then the last one is, even if that all exists, what are the preferences? Do people even want to engage with these tools? And so thinking about these different areas and if there's any differences in this, it may result in inequities. And so the last sort of framework I just want to present in our mind when we think about digital health inequities is one that has been published that talks about having generated inequities, meaning that when we roll out these innovative tools, sometimes they can actually create additional inequities depending on the adoption or implementation. And so these authors suggest that, if you have a baseline inequity in health, and then you roll out an intervention where there's unequal access, unequal uptake, unequal adherence or effectiveness for the intervention for a variety of reasons, then you may actually have an existing inequity get larger or become exacerbated because of how you rolled out the tool. And so I think this framework is really important for keeping in mind as organizations think about what digital tools they want to adopt or which ones they want to pick. And so we're on the same page. I just want to present a little bit of data just about how these inequities sort of arise or exist right now. So this first one is just looking at the data is a little old, but largely the patterns are still the same. And it looks at differences in access to smartphones and cell phones. And what you can see is in rural areas, there's lower access to smartphones. And then there's differences by income, educational attainment. Largely the differences by race and ethnicity and access to a smartphone has not has sort of been reduced, but there's differences that I'll show you on the next slide. And then there's big differences by age as well. What we're increasingly recognize is that while device access has been addressed for at least some populations, not all, but for some populations, there's the concept of a smartphone dependency, or what some people are calling the digital divide 2.0. And these are folks who use the internet, but they're entirely reliant on their smartphone for their internet access, which means they might be reliant on data that can get throttled, or if they lose service, or if they're in areas with poor cellular service, they don't have access to the internet. And we see differences in this based on age. So younger individuals, Black and Brown communities, folks for lower income families and with limited educational attainment, those populations tend to be more likely to be smartphone dependent. And then this is some data comes specifically from San Francisco that looked at sort of San Francisco citizens, and you can see again, even if folks have access to the device, they may not have access to the internet. And this is particularly the case for lower income populations and older adults. They had a smartphone, but they actually didn't have a data plan associated with it. The piece with individual skills, it's a little bit harder to assess. We don't have great data on this. And so this comes again from a San Francisco survey that was focused on digital equity in the community. And these patterns really largely are replicated when we look at individual site data or data from individual site studies. And so you can see here that in the dark blue are folks who are internet users and are considered to have basic digital literacy. So these are people who can conduct an online search, find a website, send email, or fill out an online form. And overall, you can see in the Latinx community, non-English speakers, older adults, and then folks with lower income, there were fewer internet users overall, and then larger groups of those did not have the basic digital literacy skills. So we're seeing sort of some of the differences in having the skills needed to really access the benefits of the internet and specifically digital health tools. I just have two more slides I want to present briefly on some of the inequities that we talk about. A lot of those slides are focused on patient level inequities, and just to highlight that there are also inequities that come up at the organizational level. This data is a little bit older, but it just sort of reflects how we see challenges in disseminating tools and organizations. So this looked at the adoption of electronic health records shortly after meaningful use incentives were put into place to encourage healthcare systems to adopt EHRs. And what you can see here in the first red box is that private practices with smaller providers, public hospitals, and rural health clinics just had much lower rates of EHR adoption. And then if the clinic served a predominantly Medicaid population, they also had lower rates of EHR adoption. So really highlighting that there are disparities not only at the patient level, but if you sort of go up to an organizational level as well. And then I just want to show one slide briefly about AI tools or machine learning tools, because this is increasingly something that we think about in the digital health space. So this is one of the first studies, it was back in 2019, that really highlighted it, that some of these machine learning tools have a high possibility of bias. So for those of you who are less familiar with this study, what the authors did here is they looked at a pretty popular commercial population health management algorithm that basically suggested to clinicians or healthcare teams when a patient should be referred for a population health care management system. And so the light dotted gray bar, the first one that's vertical, this is when population should have been referred for screening. And then the darker black dotted line is when they were defaulted in the program. And what the authors found here is the purple, which is the black population, and then the white population is in yellow, is that the black participants in their healthcare system actually needed to have more chronic conditions before they were being referred to the program or actually enrolled in the program. And the reason for this is that the way the algorithm was designed, it used spending on healthcare costs as a proxy for healthcare need. And for a variety of structural reasons and challenges with accessing care, Black populations did not spend as much on their healthcare. And so if by using that as a proxy, they were actually being referred at a later time. And so this is really one of the first studies to highlight the bias that exists in a potentially that could exist in a machine learning or an AI algorithm that is poorly designed or doesn't sort of explicitly consider bias. I'm just going to close off with a handful of solutions that folks have talked about as ways to sort of mitigate health inequities from an organizational standpoint, and then I'll hand it off to the panelists here. Just focusing again on the fact that since there are multi-level barriers to digital health equity, there's really multi-level solutions. And from a policy level, we'll go through sort of some policy level ones, some ones that are really at the organizational level, and then the clinician level, but really with support from the organization to develop certain workflows. While organizations are not squarely responsible for policy, a lot of healthcare system organizations, they often, UCSF, for example, in San Francisco is one of the largest employers in the city, and so they do have some sway in communicating with policymakers. And so something that organizations can do and should think about doing is really advocating for equitable policy. So this is a picture here on the left side is traditional like redlining back from 1930s as a map. And on the right side, you can see a picture of access to high quality broadband in the same region in the East Bay here in the Bay Area. And so the red and orange suggest really lower access to high quality fast broadband, whereas the yellow and green are better. And you can see it largely really reflects the same patterns as traditional redlining, demonstrating that structural systemic inequities and racism sort of that existed in the 30s oftentimes is still being translated into sort of modern day tools. From an organizational standpoint, there's a variety of things really organizations can do, and we'll hear a little bit more about that in a second. But the first is really just identifying and tracking equity metrics. So this is a picture of some dashboards from a team at Hopkins that has really published a lot and talked about this. And you can't really see it in text, but what they have is they have dashboards that look at the percentage of their telemedicine visits that are phone versus video, and then how many telemedicine versus in-person visits folks are having. And they stratified it by race, ethnicity, preferred language, and age as well. So they really made it easy for them to track the adoption and implementation of telemedicine in their healthcare system. Similarly, not only have they sort of developed these tracking tools, they've really invested in infrastructure or ways for people to identify if somebody might need additional support. So using some ethic-based tools, they essentially created a risk score to determine if people needed additional technical support, and it really built this in so that clinicians could access it and use it to provide support. I think organizations also when you're purchasing an EHR product or like another digital health tool, really thinking through equity in that decision-making process is really important. So this comes from San Francisco Health Network. When we first rolled out telemedicine, when COVID first came in, we hadn't done that in the past. And so our initial workflow is one that lots of healthcare systems were using, which was we asked sort of patients to log into a Zoom meeting with a meeting ID. It was really clear from talking to our patients and even our clinicians that was really difficult for our patients. And so we realized that our RFP for our final video telemedicine solution really needed to be as easy as possible for our patients. And so we made it a requirement that whatever solution we chose, patients would need to be able to access it simply from a text message, and it would just open in that device's browser. And so this is sort of ultimately what we this is our final video telemedicine product, if you will. And this was again prioritizing making that accessible for our patients and choosing products that highlighted equity. From an organizational standpoint, I think there's a lot to be done in terms of workflows. So, with the whole new delivery of healthcare, both telemedicine, but thinking more about remote patient monitoring tools or clinical decision support, or we'll hear some examples about use of generative AI, really developing workflows to help make sure that there's equitable access for patients, but also across different types of clinics and clinicians. So just an example here, something that a lot of healthcare systems did when COVID started becoming available, when COVID started and telemedicine was increasing adoption, was really developing workflows for identifying who might have barriers. So, what are the questions you ask, who's asking those questions, and then connecting folks to resources to address those barriers, right? So if folks didn't have device or internet, there's a bunch of the National Digital Inclusion Alliance has been working about digital inclusion for a long time, and the government actually rolled out some programs on increasing access to devices and internet. So these are things that organizations can do, which is like really develop their workflows to support equity. And then the last thing I just want to highlight briefly is just because we're increasingly hearing more about machine learning algorithms, is that there was a paper recently published by a group of equity advocates really focusing on a framework for how you think about mitigating and preventing bias in a machine learning algorithm. And what they walk through, and you can see as their guiding principle, is they walk through each phase of the algorithm development. So, what questions are you asking? What data are you using? How do you develop, train, and validate the algorithm? And then when you deploy it and implement it and sort of reevaluate it and monitor and update it, like making sure that equity is considered in each phase of that entire process to make sure that we don't run into a situation like the one I showed you earlier where an algorithm is sort of unintentionally biasing against certain populations that have already been historically excluded. So I'm going to go ahead and pass it off to the rest of my presenters, and we'll start off with Dr. Lyles.
Thanks so much, Dr. Kung. It's so nice to be here today and to talk about these topics. Frankly, you did such a great job of the overview. I'm just going to go a little deeper with an example. I also have worked at the San Francisco Health Network with you to give a little bit more flavor to it. And then I'm really looking forward to the question and answer and the discussants and all the experts on our panel today. So you just heard about a multi-level framework for how we think about digital health equity, and we also heard a lot about telemedicine during the pandemic. So I thought I would just give some examples from my work really over the last 15 years or so, but really in the last 4 years since COVID, how we've been thinking about this. One example that mirrors really well your multi-level framework that you presented is a telemedicine for health equity toolkit that we worked on during the pandemic. So at San Francisco General, we are fortunate enough to be a part of a collaboratives with a nonprofit organization called the Center for Care Innovations. And in the pandemic, we realized, as you alluded to, just the many levels that we needed to work on to stand up telemedicine for our patients, given when they, especially at the public health emergency time, when in-person visits were just not an option. So when we tackled this problem, we were sharing lessons learned across different community health centers and public hospital clinics. We were trying to think through all the different strategies we were testing that were not working or working well. And we tried to collate that into this toolkit. And I won't get into the details of it today, but I just wanted to show how well it mirrors what you just showed in your talk about how we really have to think across levels. It's a little different, of course, how we organized it, but I think some of the concepts are really the same. How do we think about leadership engagement from a policy standpoint, but also from the selection of vendors that actually support products in the languages and in the formats that our patients require, both technically, like launching telemedicine from a link like you showed, and also linguistically accessible. How do we support teams in being able to do this really and with real workflows, especially for teams that hadn't really been standing up telemedicine prior to the pandemic? And how do we support their well-being, which is another big topic in this space? And then, of course, how do we support patients and families and communities, which in and of itself is a multi-level framework from their devices and the communities and the marginalization that we need to address and sort of connect people all the way through their skills or their motivation and interest. So this is real. So I want to take your concepts and say how real it is on frontline safety net systems working on these topics, had issues and questions across all of these domains when we were faced with the emergency, and did a lot of things that we had never done before and did it well, and had a lot of barriers that of course exist. So the reason I wanted to start with this example was really just to show that it's a nuanced question. And so the two narratives that sometimes I think come across when we talk about digital health equity can be either a little overly optimistic, technically optimistic, like everybody was ready for telemedicine and the pandemic showed that we can do telemedicine at scale, and that's what patients demand and want on one side. And on the other side, people saying, digital to telemedicine really stood up during the pandemic, but certain communities really weren't able to do video visits or use portals at scale. They were really just doing telephone visits. And that shows that we're not ready, or that certain communities or certain systems aren't ready or aren't interested in using these technologies. And the answer, of course, is neither of those are true. In reality, it's much more nuanced, and it's because it has many levels to work through and many opportunities, and each individual has their own needs and preferences about how they're going to engage in their healthcare journey. And so how do we keep that in our head when we advance equity? To me, it's not overwhelming to think about all the levels. It's actually an opportunity. Well, what can I do at a different level in my project or in my organization that can help advance equity, because they're so interconnected to one another? So that's one. And then on the one more slide that I was going to show, next slide, was just, I wanted to give examples of what that nuance looks like. So of course I can talk all day about a multi-level framework, but actually I can tell you with confidence that the nuance of how people think about using technologies in their healthcare are true in every study I've ever done. So there's 3 just examples up here if you ever wanted to read more about this. The 2 left are patient-facing examples, and the right one is actually a clinician and system level example, and they're all qualitative papers. And on the left, I showed 2 because I thought I wanted to harken back to pre-pandemic. We worked in Kaiser Permanente a decade ago, actually. It's kind of wild to think about that. A decade ago in Kaiser Permanente, we used equity dashboards or equity information, like Dr. Kuhn just mentioned, just try to look at who was using kp.org in their institution. And Kaiser's a very early adopter of digital technologies. So in 2013 or 14, when we started this study, they actually had their kp.org up for a decade. So they're 2 decades in to their use of technology. And still see differences in who is wanting to use and is able to use. So we really just did some interviews with by race, knowing that that was an equity metric that they were wanting to understand and explore. We sampled across regions of Kaiser nationally and really just tried to explore what interest and needs Black patients and Latino patients were interested in using kp.org. A lot of those nuances were really about technical support and ability to use the platform, which has come up already, but also really just wanting to keep personal relationships with their doctor. And so how do we take technology and combine it with relationships, and how do we ensure that we're using it in the right way and not feeling like it's a substitute or taking away interpersonal relationships is really at the center of what we hear over and over again. So that was a decade ago. Fast forward to the bottom study, the same exact themes came up during the pandemic when we interviewed patients at San Francisco General about trying out telemedicine for the first time. Both those things can exist at the same time. They can have satisfaction and thought, oh, that was easy to do. I liked being able to talk to my doctor quickly. And they can have hesitation about, but I'm not sure about whether or not I needed an in-person exam or whether or not I still wanted to see my same doctor in the clinic in person. And both of those things can be true at the same time. And how can we keep that in our brains to advance what we're doing? Because it's, again, it's not an all or nothing solution. And then the last comment I wanted to make that exists, again, one level up at the clinic or staff level, a lot of amazing work in that collaborative with the Center for Care Innovations to think about equitable telemedicine during the pandemic across about 40 community health centers. But when we thought about language as the equity domain where there were barriers to telemedicine uptake in California in particular, we tried to sample on sites that had high proportions of non-English speaking patients to see, again, what went well and what didn't go well. And the exact same nuance comes up here, where there's amazing solutions, a lot of reworking of entire workflows. But the strongest case studies and examples of successes during the pandemic with telemedicine for non-English speaking patients in these sites was really about non-technical things like bilingual staff with deep relationships with patients and communities, the ability to leverage those existing relationships to pivot into a video visit or a phone visit were the essential components. And so how do we take both of that? How do we take all these nuanced things? I hope I'm giving you some examples of the real life of what a multi-level framework looks like, and then some positive components that we can think about this nuance and we can hold both of that at the same time. So I just wanted to sort of underscore that, and I'm excited to dig in the Q&A.
Thank you. I will pass it on to Dr. Pandita now.
Thank you, Dr. Kuhn. And thank you for that wonderful setup and introduction. So by way of introduction, I work at University of California, Irvine as the Chief Medical Information Officer, but most of my career journey has all been in safety net systems. So I was at Hennepin Healthcare prior to this, which is the largest safety net in the state of Minnesota. And 60% of our patients were non-English speaking there. We had a few FQHCs in our portfolio there. And now at the University of California, we are the largest safety net system for Orange County, actually the only safety net system for Orange County. And we have 2 FQHCs and a lot of footprint across Orange counties in areas that typically cannot access care through usual means. So with that, I'll tell you my take on when we talk about digital disparities and solving for digital disparities. I think the first and foremost, and this is my pet peeve, and it'll come across, is equity should not be an afterthought. Equity should be an underpinning to everything that we do. And the way I learned this is, how to design for equity. And I'm a big fan of user-centered design principles. And if you're not including the people that you're designing for in your solutioning, often we fail, and then we realize and have to backtrack and go back to the drawing board. And I'll start with a story, which will tell you how I embarked on this journey of user-centered design. When the pandemic hit, we had some assumptions, and I know Courtney and Elaine both talked about this, on who is digitally savvy and who is not. So we are assuming that youngsters who have grown up with phones and tablets and all that and have had access to it all along are digitally savvy. And on the other side, we also assumed, and digital disparity is not just on the patient side, it's on the provider side as well. We also assumed that digital literacy is high among these certain populations that are young and know about device and how to access Wi-Fi and all of that. It's on the provider side as well. Some of our older providers or physicians actually are not digitally savvy, and they equally struggle with being providing care in a digital manner. So you have to solve for both sides and provide tools and resources on both sides. So when the pandemic hit, in my prior organization, we had a clinic that was specifically an inner city clinic that was catering to Hispanic teens. And it was run by a Spanish-speaking physician. And when we pivoted 100%, the doors of the hospital were shut down, clinics were shut down, 100% telemedicine, I was like, this is going to be a model clinic, because these are all teenagers who all have phones. And of course, they're going to use video visits. And of course, they're going to do, telemedicine easily. And the director calls me and says, I am not able to access any of my patients. They're not setting up telemedicine appointments. They're not joining the telemedicine appointments. Even when we set it up for them, something is not right. So finally, I actually talked to one of those teenagers through an interpreter, and I said, what is the barrier? Why are you not using this? So the answer was eye-opening. It was as simple as the link we were sending to them to log into the video visit was in English, and none of them knew how to read or understand English. So they could not even launch the video visit, even though they had a device, they had Wi-Fi. So something as simple as that came back, told my team, we need to do something, and we were able to give the instructions in the patient's preferred language. The adoption in that clinic went from 0 to 80% within 48 hours of that change. So then we went back to the drawing board and said, we need to understand the needs of our community. We are not designing right. And we did a community needs survey, and this was actually published in Public Affairs, where we had about 397 participants. And most of them actually said, surprisingly, that they had internet or smartphone. And about 72% were willing to use, video visits. And a lot of them expressed openness to even using our patient portal. However, our patient portal at that time was an English-only medium. And we did this survey, got this response, and we got a lot of good feedback from patients. Telemedicine does solve for a lot of disparities in other ways, where there's geography, where people don't have to take 3 buses or find childcare, or, if they are suffering from an illness like anxiety and they don't have to come into a crowded clinic setting. So for those things, it works really well. And once we launched this and we designed it based on patient preferences, our actual, patient engagement improved. So it's not that if you design things well, you actually will get better patient engagement, but you have to keep the patient in the center of the design session. Next slide. So again, I know Elaine talked about redlining. So we have something similar. So again, talking about user-centered design, we used a metric of social vulnerability index, which is consists of 5 different metrics like income barriers, cultural and language barriers, education, insurance, housing. And this was our geography that we were serving. And with the SCI pattern, we identified that the red areas were the ones that had very high SCI. So the disease burden was high, but there were barriers to accessing care. And now the question was, how do we design a solution that these people find care in a manner that they prefer, while honoring their preferences? And anecdotally, and we were also hearing from these people that I don't want to be on video because I'm undocumented, and that'll mean that you can take my picture and send it to an agency. So these were all sort of anecdotal things that are very vital when you're providing care in a safety net system, because we are agnostic to who you are. If you have a healthcare need, you come to our system. Next slide. So again, the data drove us, and if you can go back to the previous slide. So the solution that we designed was we took not only vaccine to these areas that were in red. So we had a trusted messenger system. So most of these areas had either religious organizations or community centers, which were trusted by those people. So instead of expecting them to come to us, we took vaccine to them. The second thing we did was set up telemedicine kiosks in these areas, because we knew that these are people who have barriers to actually seeking care. They might have barriers to device. They might have barriers to even having Wi-Fi in their homes. And another barrier that came across loud and clear was these are people living in one-room apartments with a family of 5, 6. There is no privacy to do a telemedicine visit out of the home. I remember personally, I had a lady who was having some emotional and personal issues. She did her telemedicine visit from the bathroom in her apartment because she didn't want her family members to listen to, what was going on with her. So, these are all sort of things that you have to think about. So once we did the taking, care to the people, setting up the telemedicine kiosks in those trusted centers with privacy ensured, we also did this with the Minneapolis school system, because a lot of these kids were even though there was a pandemic, they were getting free school lunches, so they had access to the schools. And we said, okay, while you're going to pick up your school lunch, why don't we just arrange a visit from your school in a private setting where the school nurse could help you set up the telemedicine appointment. So just thinking about this and designing with the user in mind makes a huge difference. Next slide. So again, like I said, to me, if you look at your data and you have that equity, lens on all the time, you don't have to second guess the equity. I know organizations who have KPIs around equity, or they say, okay, one of our pillars to solve for this year is equity. Equity should be an underpinning to everything. It should not be an afterthought. It's a choice. And if you apply a racial equity lens to all your policies and decisions, and you use a user-centered design lens, then of course all your solutions will have equity for front and foremost. And then be trauma informed, because again, like I said, there are patients and certain cultural and religious groups and certain belief systems that are coming from a place of trauma that is over 500 years old. And if you don't acknowledge that, why don't they trust the system? Well, it comes from a place of trauma. Why are they guarded when they're talking to you on video? It comes from a place of trauma. So all this and being trauma informed is very important. And then, support the access. So in Minneapolis, Best Buy actually had a great idea of where they use a Geek Squad. And we did a pilot with them where we could send the Geek Squad into some patients' homes to troubleshoot how to set up video visits and, set them up with the equipment and all of that. And then, equity, like I said, I'll sound like a broken record here. Equity should not be a standalone tactics. It should be the tactics for all your other tactics. So I'll stop there, and I look forward to your questions.
Thank you, Dr. Pandita. I will pass it off now to Dr. Richardson.
Hi, great. So I'm Sophia Richardson. I'm an internal medicine physician and research faculty at NYU. I recently took on the role of director of the Division of Digital Health Equity in the new MCIT Department of Health Informatics. So it's entirely operational. And then also the role of director for the new program for digital health equity in the Institute for Excellence in Health Equity at the medical school. So both the program and division really function as one entity, reflecting a deep collaboration, the goals of the Institute for Equity with all the IT capabilities we have here at NYU. And so today I'll be talking about one of the first projects that we've worked on. You can go to the next slide. Some of my work, not the work I'll discuss today, is funded by NHLBI. You can go to the next slide. So our work with the program really is grounded in a framework for digital health equity that we published in 2022 in Nature Digital Medicine as a part of the groundwork for the program. And here we detail the determinants of digital health by level, individual up to societal. And we've already reviewed a couple of digital health equity frameworks. I won't spend too much time here. The point really I'd like to make is just to underline the point that's already been made today, which is the importance of focusing our energies on interventions that are upstream. So at the community and societal levels. You can go to the next slide. And then just highlighting algorithmic bias here. So algorithmic bias describes the systematic and repeatable errors by a computer system that create unfair outcomes. You can go to the next slide. And then I had to include a quote from Dr. Sophia Noble, who shares my very unique first name, and wrote Algorithms of Oppression in 2018, I think. And what she said is that policing and healthcare are fundamentally the most dangerous kind of predictive technology, that it really is a matter of life and death for people. You can go to the next slide. So I'm sure everyone at this point has at least heard about ChatGPT. Probably this audience, most folks have actually used it themselves. It's a chatbot developed by OpenAI and was launched in November 2022 based on a large language model. You can go to the next slide. And by January of 2023, it actually became the fastest growing consumer software application in history, gaining over 100 million users. So pretty exciting stuff. And there was immediate interest in how this tool might be leveraged for patient care. So Epic, in partnership with Microsoft, brought GPT-4 to electronic health records. And the first use case occurs through InBasket, allowing clinicians to use generative AI to create a draft response when communicating asynchronously with patients. So you can go to the next slide. And so why is this so important? So we know that the electronic health record, including messages, which docs get a ton of every day, contributes to physician burnout. And physician burnout, we know, contributes to reduced quality of care for our patients. So potentially a pretty big deal that this tool can actually help docs communicate with patients and take some of the workload off of them. You can go to the next slide. But because this tool would be contributing to the communication between our patients and providers, really our first step was to take a look at the health equity literature. So we try to be as grounded as possible in the health equity literature, and just take a look to see, what's out there in terms of communication quality with docs and patients of different race ethnicities. So you can see physicians are more verbally dominant and less patient-centered in communications with African Americans. Also, lower levels of positive affect. And we see some of that also with Hispanic patients in terms of patient-centeredness. And that was regardless of English proficiency. And then, of course, why does this matter? Because quality of communication, particularly patient-centeredness and affect, is actually associated with differences in adherence to medications. Lots of studies out there for patients that have chronic disease. So it is important. Go to the next slide. So what was our goal here? So our big objective really was to evaluate the out of the box. So, Epic really created an out-of-the-box prompt that lots of different institutions are using, not just NYU. So our first focus was to go ahead and evaluate that out-of-the-box Epic GPT-4 generated draft replies for differences in terms of patient-centeredness or positive affect by patient, race, ethnicity as part of a pilot before rolling this out across the system. Go to the next slide. This just gives you a quick sort of sense of, what the interface is like for the GPT-4 generated draft replies. So for those of you that don't use Epic on a regular basis, the top there, you can see a message from a patient about a rash. And then on the bottom, you can see it's clearly labeled as a generated draft reply. I was a part of this pilot as well. So the very first time you get the message, there's a message to the doc to let you know that this is going to happen and just to get your consent. And you can see at the bottom too, we're also collecting information about, okay, does the person getting the generated draft reply feel like it's helpful or not helpful? And then again, it's right in the name there, but it's a draft, right? So obviously you can edit it, you can delete it completely. And you can see it comes up with language that's pretty simple, pretty straightforward, but that would take, a few minutes for the provider to generate themselves. Go to the next slide. So the pilot started August 30th, and these are the dates, August 30th to about December 7th of 2023. That's when we were still using the out-of-the-box Epic prompt. Importantly, we decided to just look at the first message. So a patient will send a message. The draft comes as right after that first message is what we limited this study to, was just that first message, not all the messages that might come down the stream. All message types, and it was just 3 practices, primary care practices in the pilot, internal medicine and family medicine. We wanted to look at the total word count because there also was, some stuff in the literature too about, shorter visits and less communication in terms of communication quality between physicians and patients of different race ethnicities, the grade level, and then the patient-centeredness and positive affect. Now, what we did is we used Luke 22 software for a computational text analysis of the draft messages. Very well validated and can analyze about over 100 different dimensions of text. And so you can see right there for patient-centeredness, we decided those dimensions, clout, affiliation, and power would be key for looking at patient-centeredness. And then for positive affect, tone, emotion, pro-social behavior, and politeness, we thought would be key for looking at affect in those communications. You can go to the next slide. So in that relatively short period of time for just those 3 practices, there were over 18,000 messages. These are, again, just the first message. So it doesn't take into account any of the sort of back and forth. So that definitely speaks to issues of burnout, right, for faculty and staff. Interestingly as well, 65% of those messages were sent by female patients, 70% by white patients. And then in terms of analysis, we looked at word count. You can see that actually is the word count. So about word count for the draft message reply, 79 for the white patient, 77.7 for the Black patients. And we did find a statistically significant difference for Asian patients at 76.7. And in terms of grade level, we didn't find any difference. So right about an 8th grade level for the patients of different races. One point I wanted to make here as well is that what you'll see is we actually had to limit our analysis to just race. We actually don't have great ethnicity data for our patients, which is another huge project that we're working on. And then in terms of patient-centeredness and positive affect, you can go to the next slide. We found no difference. So good news. So no difference in terms of either of those. In terms of the draft message replies. You can go to the next slide. So just a few interesting discussion points. So when we were thinking about this and deciding if we would conduct the analysis, we realized really that some might argue that it wouldn't be necessary because the tool shouldn't have had access to the patient, race, ethnicity. Thinking more about it though, we realized it did have access to the patient's name, And importantly, the patient message, and the patient messages actually could be different. And we're realizing more and more how clever these tools can be at really recreating our social structures, even without all the tools that we think it would need. Of course, the key role, I mean, that's really what I would underline here, of always, pilot testing and evaluating, and assuming that you're going to find bias and harm. So we really believe pretty strongly that these tools really should always be launched in controlled, evaluative pilots. And then, of course, the iterative nature of testing and evaluation. So this is really just our first bite at the apple. We intend to keep looking and poking around and evaluating as we scale it out. So going to look at differences in patient messages, also the impacts of the staff and physician edits. So this was just a look to see what the AI was generating, but there's lots of questions around, okay, how do, staff and providers interact with this tool, and do they do that in a way that creates bias or harm? And that's it. So yeah, excited to talk more during the Q&A.
Thank you. And then I'll pass it off to Dr. Shen for the last set of comments here.
Great, thank you so much. It's a wonderful set of presentations, and I'm going to try and respond both in a few remarks about one project I'm working on, and then stepping back with a couple of slides to pick out some of the ethical and legal challenges that I think permeate across this space. So we've already heard some amazing things. Dr. Kung gave us a wonderful model, if you remember that slide, of a framework for how to do this right. Dr. Richardson said, we started everything with this framework for digital health equity. Dr. Pandita reminded us that you should start, and I'm emphasizing start, with designing for equity as a priority. I want to throw a monkey in this wrench, which is, what happens when the technology that shows up in the clinic or in the hospital, in the institution, didn't follow any of those frameworks, didn't include these issues from the start? What do you do then? Next slide, please. My interest in this goes back in neuroscience for many years, but in AI about 5 years. And we've been working with a number of colleagues here at MGH and Harvard and across the country around issues of justice and equity. I've worked primarily in psychiatry, psychology, and the law on these issues, with this big question being, I think, similar to the previous presentations, how can you leverage these technologies for the good? Next slide, please. So as I mentioned before, our previous presentations have given us some really awesome ideas about how to do this right, and in particular, the importance of representative training data. And if we were starting from scratch, I think we'd be in a decent place for mitigating bias and addressing some of the other concerns that have been raised. Next slide. But, next slide here, there we go. Many tools will arrive, and frankly have arrived, on the market that did not utilize these strategies and did not train their AI models with representative data. Next slide, and there's no time machine. This is also my excuse to put the TARDIS and the DeLorean on a slide. We can't go back and change them. Next slide, which I think raises some real questions. Now, first of all, we should ask, why isn't the data representative? First of all, we may just not know. We just heard conversation on, we might just have the data, the relevant demographic data. The technology developer of the hospital is transparent, but just says, we just don't know which type of humans are in our training data. Secondly, it could be that the data is not representative, or we don't know if it is, because those variables weren't rigorously measured. It's a real problem. And then finally, for those companies that are developing these digital health tools, sometimes we won't know because it's proprietary. The black box is there and they won't share the data. Next slide, please. So I think we have, some real concerns. And again, it probably matters why the data is not representative in terms of the ethical analysis. Was ignorance, like you just didn't know? Some of the frameworks we've just decided they've only been developed in the last few years. Maybe they weren't aware of them. Was it a deliberate choice to maximize profit? Were there capacity constraints? Like the developer says, I would have loved to have 10 times the number of participants in my training data, but I've already taken out a second mortgage on my home. I've sunk everything into this app. I can't do anymore. And this happens a lot, this final item. Hey, it's only pilot work. We'll do the more representative stuff later, right? That happens sometimes in different stages of clinical trials. So I think those are some of the reasons why we end up in the place we do. Next slide. I really want to focus on, what do we do? So one option is, Not a big deal. Just let's treat it as if it were a representative data set. Let's treat it as if they had used an equity framework and just not bother. A second is to proceed with caution. Let's use the tool, but be really careful. And the third, which some colleagues I think would advocate strongly for, is go back to the drawing board. You cannot move forward unless you have done this the right way. Now, how long will it take to do it the right way? And can we wait that long? I think that's a real challenge. I'd suggest, from my view, that option 2, thanks for the animation, proceed with caution is the right way to go. But proceeding with caution means, to me, the following things. Next slide, my final slide in this set. To proceed with not just kind of a general caution, but specifically with guidance on how to move forward from interdisciplinary teams. You've already heard examples from that in previous presentations. I'll give a plug for the NIH Bridge to AI project. It includes multiple teams, I'm on one of them, that are trying to come up with guidance for researchers and developers in this field. We, and I know many others, have published different ethics guidance. A couple of those are there. And I think proceeding with caution also means, and you've already heard this on previous slides, it's what we do in our work, engaging with relevant communities and stakeholders, and just some of the work that we do pictured there with relevant neurotech stakeholders. Okay, next slide. So I'm of the view that, proceeding with caution and proceeding with ethical guidance is really important, which begs the question, well, what are some of the really big ethical considerations? And I'm going to offer just 5. I think these are some of the top 5, though there are many more, and I'm sure we'll reach them. I hope we will in discussion. First, number, please. Okay, so we just heard about this from Dr. Pandita's work, which is what David Simon and other colleagues have called the bycatch effect. Now, I'm not a commercial fisher person, but this term comes from there. And the idea is that when you throw your net in the water and you want to catch fish type A, you also get fish type B and C and D and a whole bunch of others. That's your bycatch. And when you use digital technologies, many, though not all of them, will pick up other stuff beyond just the patient. This is a big difference. If it's just the patient coming to the clinic and the clinician is meeting with them, there's nobody else in the room, maybe a loved one. But now, as you've just heard, you're turning on Zoom, you're seeing the entire house. Maybe you're doing 24/7 recording with ambient sensors. You're picking up what you think could be evidence of abuse. These raise real ethical, security, privacy, legal concerns that are unique, I think, to digital tools, remote tools that are picking up lots and lots of information. Okay, number 4. This is a real challenge. Institutions, and this is, institutional ethics conversation today, are under real pressure to increase revenue or maintain revenue levels, for instance, by expanding concierge service or something like that. And telehealth is no exception. It's good evidence that the way telehealth has been rolled out over the last few decades has been very, of course, cognizant of the bottom line. And while it's possible that deployment of the tools we are learning about and talking about today may decrease costs and appeal to efficiency, which is sort of like, hey, it's a win-win. We can improve equity and efficiency. Everybody wins. In some cases, really pursuing digital health equity, like what we've heard today, providing additional support. We've heard about the need for multiple languages, follow-up care, sending out the geek squad. Well, that's going to require more resources. And I suspect that there is already and will increasingly be this tension between doing it the right way and doing it the most cost-efficient way. And that's an institutional concern. Point 3. And going back to, a standard bioethics principle of beneficence and the need for evaluation equity audits, we're learning a lot and talking a lot today about implementation. This stuff is so new that it's really critical to understand if and how and why these tools are actually working. That's really tough. It's easier to implement than it is to assess and to audit. This isn't new or unique to this space at all, but I raise it because I think it's there. And in particular, and we just heard this concern raised in the last presentation, it requires careful consideration of the relevant population descriptors and granular data disaggregated by relevant groupings. That could be geography, that could be disability status, that could be pregnancy status, that could be gender identity, that could be race and ethnicity. These tools may not work the same for everyone. And it seems to me important to understand if that's the case, why that's the case, and then potentially how to address it. Okay, number 2 and number 1. I think number 2 is just such a critical issue here. And I put it under the title of data justice, data ownership, data control, and data stewardship. And I'm going to reference a colleague of mine, Dr. Jonathan Jackson, who founded the MGH Center for Access, Recruitment, and Engagement, as a absolute innovator in the area of community engagement around clinical trials and biomedical research. And he and I and others are co-authoring a piece called Decolonizing Neuroimaging Research. And I think it's more broadly, obviously others have talked about it too, the model that generates a lot of the tools in digital health, in my view, works something like this. Okay. Gather a lot of data from participants, and sometimes, pay them if they're participating. Otherwise, just grab it, and then maybe it's de-identified, and then develop these models. And either, if you're an academic, get prestige from it and go up the ranks. If you're a developer, make money off it. And what about the folks whose data were in that training model, who contributed to the system? No one thinks about them. They don't own their data. I think that's a real problem. And what will institutions do with this data? I've seen multiple institutions look at this as an opportunity for repackaging. And now it's de-identified, but entering data use agreements with other developers. So I think we ought to come back to this. I hope we do in discussion. All this data that's being collected, who is it being collected from, and what do they get out of this? Okay, and number one, the top issue, I think, is an ethics of patience. My colleagues on this call do even more than I do. The work that I do has taught me the lesson that it's like community engagement 101. So I say silly almost even saying it, but I think it's important to make it explicit that the frameworks we've just heard about, to do them well, is really tough and takes a lot of time. We've heard in each presentation the need for deep engagement, and that might be with community, with clinicians, with multiple groups. The average tenure for hospital CEOs is about 5 years, and VPs, like vice president for engagement and vice president for research, they turn over when CEOs leave. And so I think it's really important that, I'm thinking about institutional ethics, that the commitment to engagement, the commitment to the things we're talking about today, doesn't rest in individuals, though you do need champions, but also in institutions. I've heard multiple times across multiple institutions that when there was a leadership change, everything changed. But the new leader came in and wasn't as interested in this. That's a real problem. If engagement takes a long time, and there's going to be leadership shifts in the institution over the course of that time, there have to be ways to have it embedded in the culture and the ethos, and frankly, the budget of that institution. There are many quotes around community engagement. This actually comes from education reform. I participated, kind of cut my teeth doing education reform before moving into health. I'll just read it. I think it's a nice reminder and a nice way to end and segue into discussion. Doing to us, not with us, is a recipe for failure. This work takes patient urgency. I think there's attention. If you aren't patient, you only get illusory change. Lasting change is not possible without community. You may be gone in 5 or 10 years, but the community will still be there. This is speaking to reformers or developers, professors. You need a sense of urgency to push the process forward and maintain momentum. So I think this ethics of patience is really required of institutions. And I think that expecting systemic changes in 3 months, 6 months is unrealistic. And if it's set up that way, that those are the metrics, I think that causes a real I think that sort of infiltrates the discussion from the beginning. So from the beginning, I would add to the things that have already been said before, recognize that doing it the right way takes time, build that into the institutional framework, find a way to concretize it, and then, okay, so the CEO changes, the new CEO comes in and says, I might change a lot of things, but one thing I'm clearly not changing is our commitment to this, because it is part and parcel what this institution is about. I'd love to see that. I don't think we're there yet. And I'll end my comments there.
Thank you so much, Dr. Shen. So we're going to move to the Q&A session. I'm going to stop my share. We have a couple of questions prepared already for the panelists, which I'll start with. But those of you in the audience, feel free, if you have questions, to raise your hand or drop some questions in the chat, and we will try to incorporate some of those. So I'll start off with sort of the first question, which I think Dr. Shen really highlighted in his closing comments, which is that a lot of these sort of digital health tools, these innovative solutions really require and benefit and only develop a sort of significant amount of data. So I'm just wondering how sort of folks in organizations you've been working with, how do you weigh the challenges of sort of leveraging these massive amounts of data while protecting individual patient rights, and how do you think about that? And I'll open that up to sort of anybody in our panel.
I'll jump in first and say it's very true that data, especially with the AI, so there's 2 points I wanted to make in response to Francis' comments and sort of in the space of data. The first is that we are moving forward rapidly and the data are biased. And I think we all realize that. I think the challenge that I always come back to are two. First is that the systems in which we have been actually doing a better job with equity. So I'm talking about safety net healthcare systems and systems that actually do have equity as a priority in their organizational structure and have had it for many decades. Their data are not even present at the table for AI in many cases, for AI or for other tools. So I want to talk. So when you asked me about significant data, I'm like, there is no AI tools being generated at San Francisco General Hospital with our electronic health record data. So I want to bring that up. And then when we think about the tools that are being developed, I think we know that they're biased in terms of who comes into the healthcare system and what kinds of treatment they get and all of that. So like, I was wondering if we could flip the script on the data conversation and really talk about our power as academic institutions. We've spent decades doing health services research. We actually know a lot about our electronic health record data. We need to be more forceful about what's there and what's not there. We're not going to change private development of AI, but I don't know. I wanted to talk about sort of the flip of this conversation into a different direction. So would love to hear the other panelists' thoughts about that.
Yeah, thank you for setting that up, Courtney. So again, I would say one, it's all about consent and transparency from the patient's lens on one hand, but then on the other hand, the institutions have a responsibility to invest in being responsible around their data too. So take the example for AI that you were bringing up, how are institutions, when they are developing AI tools, even if they have the capability of doing that, how are they ensuring fairness and accountability and transparency and, while protecting individual rights and mitigating bias? And you're right, the data that is being used to study or develop AI tools is not a representative data set at this point. And neither are, because there is a rat race right now to put tools in the market. And most of the AI developers have a 6-month, because ChatGPT just came out, less than a year ago, or about a year ago. So there is a competition going on to put the tools in the hands of the healthcare systems. However, in 1 year, they don't have enough of a robust data set to study their tools on. So now it falls on the healthcare systems. Do you have AI governance in place to sort of evaluate these tools to make sure that the bias in the algorithms is evident, or has it been studied on a representative data set? So I think that is the conversation that needs to happen. The problem is that takes a lot of resources, and it takes a lot of due diligence on behalf of the healthcare systems that are vetting these tools.
Yeah, definitely. I mean, what this question actually made me think about was, I think because my work really focuses on healthcare providers, issues with like balancing, using data and protecting rights comes up for us when we're trying to get data about providers, about physicians, to use, particularly race, ethnicity. And so the institution I was at before, and NYU, HR, it's a lot of trouble trying to get from them this kind of data. It seems like really they've moved towards really not sharing it, which makes it difficult to look at, I think, important things around, race concordance when we're studying these topics.
Yeah, maybe going back to some of the comments about sort of flipping the script a little bit, I'd love to I practice in a safety net system in San Francisco, and agree a lot of these tools, right, they're developed with whatever data sets are available, right? So if there's a large healthcare system that's been partnering with Google, that's how Google has developed their AI algorithm. And I think safety net systems or healthcare institutions which really have cared for historically communities, I think they sort of they really worry about getting the data from their patients sort of exploited, if you will, or sort of being used, develop sort of these for-profit commercial tools, and then not benefiting from the use of that data. And so, at least where I practice, there's been some resistance to making data available for research or for development. On the flip side, right, if that data is not available, how do you make sure that these tools being developed work for those populations? And I'm wondering if folks have thoughts about that, or have seen how organizations have struggled with that, or gone about sort of weighing the pros and cons of recognizing the importance of having that data represented in the data set, but not wanting to give consent on behalf of, like all their patients that they care for.
You gave the answer partly yourself, Dr. Kung, is the consent part, and therein lies some of the concerns about data literacy, because when patients are consenting, they typically don't know what they're consenting to. And so being transparent in the consent process is very important. And the second thing that has been brought up repeatedly is our EMRs are sadly lacking in collecting demographic information accurately, especially as it applies to race and ethnicity, in terms of even within advanced institutions getting a representative data set. I mean, that's why whenever we do a study, we don't rely on the EMR to pull the race and ethnicity data. We actually design it as part of the study collection, forms or whatever. And then the third thing is patients themselves, when they are talking about contributing to research, even if they consent to it, they actually don't know the nuances of what they're consenting to. How will that data be used? And oftentimes the institution themselves may not be able to answer that question. They may be part of larger consortiums of data that they don't know what the future use case for this data will be.
Yeah.
Sorry. Oh, go ahead.
I was just going to add really quickly. I think this is what I see also is a siloing of the health equity leadership at organizations and the informatics leadership. And this is that would be a great example of the health equity leadership, like genomics data. There's a lot of other sensitive data that we've been thinking about consent and other processes, but that hasn't really been translated into how we think about informatics kind of tools. And I think there's some differences in how it's similar to what Francis just showed. It's a slower process, but we have to be engaged within our own health systems to talk about these issues to really make change. And I don't think I don't think it has to take 10 years. I just think we really have to be together in a way and using our expertise better to make changes.
Yeah, just on the consent bit, there are a number of scholars, I'm amongst them, who are sort of reject as insufficient the notice and consent standard. The basic logic is we won't have to worry about privacy if someone said it's okay. But as you point out, Dr. Medina, no one knows what they're saying. It's a farce. There are things that can be done. I don't know how much are being done. I'd be interested to hear if your institutions they are. For instance, data use agreements that bind the user of those data in a certain way. In addition, there are innovative ideas that are not mine that I would advocate for, where communities can financially benefit from these. Now, one of the challenges, you got 1 million data points. What are you going to give everybody a $1? No, but they're a collective community trust. It's not a hard problem to solve kind of administratively. And I'd be interested, I haven't seen that done at the institutions I've been involved with. That would make folks much more interested in participating. It's not just their goodwill, you're going to help future generations. It's you can build a new building because you're going to get X% of the profits are going to go into this trust. So I think there's some real ways that it could be done. I've seen scholars propose them. You all, and maybe someone on this call will know better if they're being implemented by some of the large institutions.
Looks like there's a question from
Yeah, Doctor, I was gonna Dr. Richardson, did you have comments, or I was gonna go over to Dr. Fernandez? That's okay with you. Dr. Fernandez, you had your hand raised if you wanted to jump in with your question.
Thank you so much. And thank you for this incredible panel and discussion. And I agree with the person in the chat. It'd be lovely to continue the conversation beyond this. So I had two comments. One is, you know, there's so much embedded. For instance, we're just transitioning to EPIC soon at BILH. And in many aspects of EPIC, as you know, like even in the way the reports about payer-specific reports and so-called compliance with respect to quality metrics get displayed are by definition, you know, done by payer and therefore tend to make the lens towards maximizing, because of value-based care in those groups in different ways, what we do for different groups. This then pervades how we do our population health outreach as well in many ways. What I wanted to ask you is, as we're setting up and we're going to allow patients to self-book appointments, whether there is any model out there that allows for greater equity so that you reserve a certain amount of appointments for those who don't have portal access. What are systems doing with respect to really taking into account with anticipating the disparate portal access and engagement?
Great question, and that's my life as a CMIO. That's what I do for a living. So, I'll give you a few suggestions that I have incorporated in the organizations I have worked for, and there may be others that others have ideas around. But one thing I would strongly caution you is when you do any of your dashboards or metrics or anything, out of the box, EPIC does not have the race, ethnicity, demographics, and all that data. You have to set up the models yourself into EPIC. It's available through Slicer Dicer. So make sure that you have the models enabled as you set up EPIC, and then you can automatically plug and play them into any of your metrics. So that is one thing you should do off the bat, because that way you get that view that you typically would not get just from a payer metrics or just quality metrics. You have to plug in the health equity metrics. The second thing is, if you have the ability, and this is very resource incentive, to enable patient portals in the patient's preferred language. Now, there are too many languages to address, but at least if you can address the top 2 or 3 in your organization, that would be one way to solve for that. And then the third thing is use, and this is where AI actually is helpful, because AI is a good translation tool. So if you have web-based scheduling mechanisms, and this is assuming that the patient has access to the website, those auto translations are the web-based tools in terms of picking up on the patient's preferred language and then using that to schedule is very helpful. It does streamline the process. And then have dedicated phone lines in the patient's preferred language for scheduling.
There's no other comments from the panel on that question. I might go to Dr. Craig. Dr. Craig.
Thank you so much for an amazing presentation. I am rejuvenated in my own fight and feel that I am not alone for the first time here at CHOP in Philadelphia. The other area of connection that I wanted to call out specifically to that point about when you're turning on EPIC for the first time, here's some, oh, by the ways, don't forget to ask for this while you still have some EPIC support. Language is an area where out of the box, you get about 130 languages. And if you want to add anything like Hakachin or any other languages, you have to do it individually. So there is a momentum of work being spearheaded by folks I know at CHOP, as well as Denver Health, to advocate for EPIC, that out of the box foundations build for language category options will be more robust and comprehensive. And there are advocacy platforms for that. Epic has an equity brain trust that meets monthly, and a language subgroup, language and interpretation and translation subgroup, that you can bring these advocacy points forward. And I would hope that in any ongoing collaborations, Elaine, I can't wait to join your group, that, you know, if there's basically a petition or a union of us that says, Epic, this is the way you should go, walk in it, that I think that there could be some real change that could happen to say that all of us don't have to individually add Hakachin into our language lists. But I think that that just is another area for potential collaboration and advocacy.
Thank you. If the audience has any other questions, please jump in. Otherwise, we have time for maybe one last question that I'm going to throw to the panelists here. You know, I think we've talked a lot. You know, obviously, Epic has a lot of sway here. I'm wondering how you all think about sort of like whose responsibility it is to sort of pay for any costs associated with advancing sort of equity, right? We've talked about how we need, you know, it takes time to engage folks, and then oftentimes, you know, money if you're rolling things out in multiple languages. So like, who's responsible, you know, for the cost of advancing equity, and what role do you feel organizations have to play in advocating to vendors, right? EHR vendors, policymakers, sort of other folks who are in this space that can create a more equitable environment or equitable infrastructure.
Keep jumping in first, but I have ideas. I think this, again, same with AI and the same with this return on investment kind of, you know, as a business case. Both of those have been around a long time. I mean, the business case for health equity for other digital implementations or for different programs, there's a lot out there that show that you can save money. So I wanted to say that. I think the thing that we all struggle with is our incentives are not aligned. Return on investment or return on health is possible with equity. I believe that full force. But when you're in a fragmented delivery system, who's getting the money back, right? I think that's the issue that we at least I keep bumping against in a fee for service and in a different environment. It creates disincentives for us to really prioritize this. But I believe firmly, and I just want to say that out loud here, that it's cost effective to do this right. You know, the same way when we implement all sorts of other technologies and tools and programs, we know that there's a need and we should be prioritizing need, and that we can improve health and we can reduce costs. I believe that, but I think sometimes we get caught up in the downstream part of that rather than the real ability to invest. So it's a very large problem of policy and incentives in our societal investment. But I just wanted to bring that up. I think it's possible, and I think we have lots of other models that we can turn to here, and maybe but basically just not reinventing the wheel and really trying to think about how to advance those conversations. And I do think we all have a role to do that well.
Yeah, I think for us here, a lot of the incentive and the drive has been around reportable quality metrics. So I think to the leadership here, you know, that sounds like money to them. And so equitable care is higher quality care, and that's what we've been doing.
I'll take a more philosophical approach here because, like it was pointed out, no one has done the economics of health equity, you know, and that's a study waiting to be done because I think that will guide us the most. But ultimately, we know from a population health lens, you cannot have healthy societies, healthy communities till you address the health of the entire population. And if you are not addressing the population that has the highest disease burden or has barriers to access healthcare, then of course it's going to always be a losing proposition from the pop health standpoint. So I think as we move more into the value-based care paradigm, weaving this conversation into the pop health value-based care delivery mechanism is what will get us there. And that is where I think as CMS and other organizations look at reimbursement for value-based care, they definitely need to keep equity front and center in terms of incentivizing based on addressing equity and access. And only then will the value-based care bear fruition. Otherwise, it's going to just fall apart like all the other CMS initiatives.
Great, thank you. I know we're wrapping up near the end of the hour. I want to thank you all for joining me today and engaging sort of in these questions. And I found it really insightful, and I'm glad I've had an opportunity to chat with you all about this. I know we've had other conversations, but it was great to bring you all together. I'm going to pass it off to Charlotte to sort of close off with some remarks on the consortium. And just want to thank everybody again for their time.
And thank you, Elaine, and many thanks to all of you on this panel for a program that somehow you've managed to be both wide-ranging and nuanced in helping us understand some of what's at stake for patients and providers when we're trying to design, implement, and evaluate digital tools, and consider how to proceed when aware of their shortcomings. Thanks to our audience for taking the time to join us and participate. I can see from the chat there is interest in following up on this discussion. And I know that you have together really raised awareness that's going to be important in moving forward with integrity in efforts like this across the country. I also want to thank two organizations from UCSF where Elaine is affiliated, and I want to thank them. These are the Center for Bioethics, the Center for Vulnerable Populations, and the Solve Health Tech Incubation Partner for Digital Health Tool Development, both of which co-sponsored this program and have shared the word about it. And I want people to know, if you missed part of the program or you want to revisit it, that you can join other people who didn't get to come at all when the video is posted on the Center for Bioethics website. And that'll be in a matter of weeks, probably. You can check it's their Facebook page. Finally, looking ahead, I invite people to join us on March 29th for the next program in this year's series. This time we'll be looking at ethical dilemmas for organizations in trying to integrate medical and social care to improve health equity. What priority do you give one or the other when you are struggling to find the resources to do everything? And what are some of the important dimensions of decision-making around that? That's going to be a very heavy in audience participation, and we invite you to come and join. Registration is always available on our website. With that, thanks to everyone, and we are adjourned.